So I'm going to, let's see, forward. Here we go. So we have over 300 days of sunshine a year in Colorado, so we have a lot of patients who have sun damage. And from a perspective, I don't know why it's not advancing, from a perspective of etched lines and wrinkles, this is a common patient that I think we all see from around the world who may be type 2 skin. So from a perspective of deep etched lines and wrinkles, I don't think we have very much choice. I think many of us would choose resurfacing. Many patients actually think that they're going to come in for neuromodulators or fillers, but I show them a picture like this, and we can only get into the lines that we think that we can get into. We can't get into all the lines here. So, painstakingly serial puncture going into all these lines is, I end up doing fillers on some of these people, but they don't really understand that they're going to have down from this as well. So doing fillers for this area requires sometimes them to come back, and we'll do some pulse dye laser to help with some of the bruising. So I would rather just kind of take everything together and use fillers for the nasolabial fold, the marionette, the cheek, as well as resurface the area. And honestly, many of our patients, you look at them and the only thing you could really reasonably do would be resurfacing. And this is something that I will do while they're awake with regional blocks and oftentimes a nitrous mix. So my practice has really shifted more towards bigger downtime procedures, but less often with heavy resurfacing like this. So I indicate here, I think the pendulum is swinging back to heavier resurfacing. I still use a lot of fractional ablative resurfacing. I do skin cancer surgery, and this patient, I repaired a melanoma in situ defect, and then starting at 2 months, I zipped over the area a couple times to make the scar look better. I'll still use a lot of fractional ablative resurfacing for acne scars and other types of scars. And this particular patient, I use fractional ablative erbium so that I can hopefully blend and minimize the appearance of those acne scars. But many patients, I'm kind of doing both, where I'll do heavy full field erbium around the mouth and eyes, and then I'll do fractional on the rest of the face. And I think it's important that we show patients what that looks like so that they understand the healing process is going to look different based on what was used in different areas. Oftentimes they'll think yellow discoloration is a problem, but we know that that's fibrin, and oftentimes if you don't tell them ahead of time post-inflammatory erythema is going to happen, they think this is problematic. So I'm used to actually telling patients that things are going to take time. When I do a pedicle flap, I tell them it's going to be 6 or 8 weeks before we get to our destination, and very similar with resurfacing when you're using a combination of devices. I tell them it's going to be probably a couple months as well to get to our destination. So, and sometimes this can be transformative. This patient has photo damage plus acne scars. This is one heavy treatment, and this made a major change in his life, in her life before a life event. So I think it's important to recognize that there are potential issues of this, and one of my many unflattering nicknames is Safety Joel, and my wife and others gave me that nickname, and I think they all make fun of me every day, which is great, and I love it. But whenever we do things, like, I always think about what can potentially go wrong. So when they're swimming, I say, look, you guys want to wear sunscreen, try to swim in the shade if it's possible, wear a big hat. If we're playing Nerf gun war in the house, wear your glasses. You always have to have eye protection. I got hit in the eye with the Nerf gun. It was not good. And then when we're skating, wear a helmet. So these are things, many of these issues are my issues that I'll show over the way, and some of them are in this chapter I did with Jacob Inda in Dover's textbook. So persistent erythema, I think, is what Jay Burns calls the highway to get to the destination. I expect this. I show patients pictures. I show them my pictures. This patient had full field erbium around the mouth, and 3 months later, she still has persistent erythema. This is not an adverse event in my experience. This is expected. Usually this goes away by 4 months, but if you look at these photos, she's had a great result, right? So I'm not so concerned about the persistent erythema. It'll go away. I've tried things like topical vasoconstrictors. It doesn't work. I bring people in sometimes and do some pulse dye laser if it's at 3 months and they have something going on that's hard to cover with makeup. And I tend to not use topical steroids because many of these patients are fair complected, and I don't want to set it up where they start to get some reactive neovascularization and telangiectasia in the area. But I think you could reasonably use some topical steroids. So I just tell patients wait. So, one of the other issues is really when you have a good result on the upper lip and you don't have such a good result on the lower lip. And that happens to some of my patients more prior to me asking Jason Posner to tell me using OCT what the difference is in the depth of the wrinkles and the diameter of the wrinkles and some of the other characteristics using OCT. So he actually showed me that it's exactly the same as the upper lip. So if it's a guy, you have the same terminal hairs, you have all the same features. So after he did this particular little project on this woman and other patients showing me that these were essentially exactly the same, I ended up really approaching the lower lip and the chin very similar to I did the upper lip, and I think my results have actually gotten better. And I just want to point out the whitish discoloration, which I think is actinic elastosis in the pre-picture, because we're going to talk about that in a second. So you can see here in the post picture, she has significant improvement in upper lip lines, lower lip lines, chin. The characteristics of the rest of the skin look better. And then you can see sort of, is this like an overexposure of the flash or what's going on before and after. So I just want to talk about pigment alteration a little bit. So is something hypopigmentation or is it actinic elastosis? I don't know, but this patient had never had a procedure before on her upper lip, and she has some whitish discoloration. It kind of looks a little cobblestoney. I'll show some other examples. She's happy with her improvement, and I think that this is what we kind of expect. But some of these patients who we study a post picture and say, is there pigment loss there? There seems to be some pigment change or hypopigmentation oftentimes in the pre-picture. So this one, she's had tremendous improvement after resurfacing, and she had whitish changes on her upper lip from sun damage in the first place. So this patient has had major improvement in etch lines and wrinkles around the mouth, and you can see in the little corner there, is that some pigment loss? But she's still happy with the procedure, and I think that the results speak for themselves. But when we really think about the difference between erbium and CO2, erbium is something that Jay Burns has written a lot about and published his series of 20 plus years. And I think it's important to recognize the difference. Erbium binds water 11 to 16 times more effectively. Erbium, you can actually disperse the heat. It's less likely to have issues related to bulk heating. And most importantly, you have an endpoint with erbium, which is pinpoint bleeding. So my endpoint right here is pinpoint bleeding. So for any of us who are old enough to have trained with some dermabrasion, this is exactly where we ended with dermabrasion too. So when I see this type of bleeding, I'm actually picking off these fine lines myself and just going through some areas that remain, but this is probably a good time to stop. So I don't think there's any other treatment that can give you this kind of result and a durable result than erbium. This is at 5 years here. So 3 years, 5 years. So I think full field erbium is important in my practice in the perioral area. And I think when you're doing heavier resurfacing, especially as I indicated around the mouth and eye, you just have to realize and talk to patients about post-inflammatory hyperpigmentation as well as erythema. So this patient, after resurfacing, went on a kayaking trip. She wore a hat but didn't wear sunscreen. Obviously, the reflection from the water to her face wasn't very helpful, and this pigmentation became my issue. Despite the fact that I showed this patient to the following patient at her consult visit, you can see here, this is a month after. She had nice results from the etch lines and wrinkles. The problem was she just didn't use sunscreen, and then this became my problem. I even feathered out in the perimeter, but she just didn't use sunscreen. The weather was nice. It was March in Colorado. You can see April, she's got this PIH, and then it becomes my problem. So let's talk a little bit about infection. Infection can happen. HSV, bacteria, yeast. Obviously, somebody comes in and they have HSV like this, you're going to cancel the procedure. It's much better to actually just do paperwork, have a staff meeting, or do something, but don't go ahead and resurface, because the issue is that you could actually have a fulminant reaction in the area that you've abraded completely. So these are all circumstances. Every single one of these that I'm going to show, these 4 are my fault. So this is a patient who, despite acyclovir for 5 days, starting 2 days prior, had HSV. This was in the day and age before valcyclovir was generic in the US, so acyclovir was so much cheaper, many patients used it, and the bioavailability is so much less that valcyclovir is 70% more bioavailability. This is the only patient that I've seen who had non-ablative fractional that actually had HSV problem. This is a patient that I did Mohs reconstruction on. I'm so worried when I'm ever on the columella area that the problem is I didn't even ask her if she has frequent cold sores, and she did. And then this was my problem, my fault. I didn't ask her. Fortunately, the repair ended up good and the columella looked good, and I was all worried about Cupid's bow, and everything worked out. And we have these medications. And then this is somebody, the only case that I have ever known where I did fillers and patient had HSV. I still don't prophylax for fillers. But resurfacing is different. We're treating a whole area. So we want to make sure patients take their full script. This patient stopped early. You can see the HSV there. So she stopped Valtrex at 5 days. This is HSV at 7 days. Fortunately, she ended up healing okay. This is Robin Sipperstein's picture of Kaposi's varicelliform eruption, where it can spread potentially to the entire area that's resurfaced. This patient was a pediatrician and thought that she had HSV, and she broke through, but this looks like a little pimple to me, and it was. So there lots of ointment. If you're using lots of petrolatum, then you could have an occlusive issue, and this is what it was. So overlap, this is a non-ablative fractional laser. This is my fault. I just overlapped a little bit in the décolleté area. And then non-compliance happens. So I tell patients, use exactly what my post instructions say. This patient, instead of just using white petrolatum, she used a topical antibiotic for reasons unknown. She just thought it was going to prevent infection, even though we tell her not to. So she ended up coming back in 7 days later with this picture. I did a KOH. It was positive for yeast. I put her on diflucan, and then she came back a couple days later with these bumps all over. I did a culture, and it was positive for Staph aureus. So sometimes you just want to say to the patient, why didn't you use the stuff I told you to in the first place, and we wouldn't be playing this game here. So this is another patient who I resurfaced her. She ended up going away unexpectedly skiing for a few days, and that happens when we have powder days in Colorado. And in her little travel bag, she forgot to bring her ointment, and she went out to the store and bought Neosporin. And when she got Neosporin, this is what happened, a whopping contact dermatitis, and then it became my problem to deal with. So these are major things that happen when people just don't listen. So I gave this patient literally petrolatum, and she went home and used her favorite moisturizer, which had glycolic and everything else in it, and you can see this irritation here. So, and then always be on the lookout for infection. This is a patient that I resurfaced her face, her neck, and her chest. She called complaining of itching, bad sign, and little bumps, another bad sign. My staff said, I wonder if this is an occlusive folliculitis or something like that. And I got on the phone with her and I said, where is it exactly? And she mentioned her shoulder, and I didn't resurface her shoulder. And this turned out to be positive for Staph aureus on a culture. So this is a patient who went on a cruise 10 weeks before. She was still coughing, and she had had some pneumonia process, and they had cultured it in the cruise. She never told me that, and she was on cough suppressant when she came in the office. This is her resurfacing picture, and fortunately she ended up healing okay. And what else can happen? So eruptive keratoacanthomas can potentially happen. I've seen this a few times. This is a colleague who circled these areas after resurfacing. I would have left this alone. Just to be very clear, I would not have biopsied this. I would have followed the patient every day or two to make sure they weren't getting bigger. But when you look at a biopsy, are you obligated to treat? This is a patient had 3 eruptive keratoacanthomas where they fell on the ice. And this, is an issue, and it's been reported not only with surgical procedures, traumatic procedures, laser resurfacing, ablative, but also non-ablative. So, and it's been reported with photodynamic therapy as well. This is a patient of mine who had PDT, and it looked like eruptive keratoacanthomas in a couple spots, and we just followed. So for this patient, I would have just seen every couple days. This is after a resurfacing. I saw this patient have what was a biopsy-proven eruptive keratoacanthoma. This is after non-ablative fractional, a biopsy-proven eruptive keratoacanthoma that I wrote up a couple years ago. So when you see this now, I tell these patients this reactive process can happen. Let's just wait, and it'll hopefully go away, as it did. But I just see these patients every day or two to make sure they're not getting bigger. So I think I'm going to end there just to stay on time. But I haven't seen what I would determine as significant real hypopigmentation this way that the way that we used to with patients from CO2. I still see these patients every once in a while that come into the practice that want to try to repigment the area. And this has happened with fractional. This is a patient that I inherited. And you can see it looks like they overlapped with the fractional, and it looks like they ended very abruptly at the chin. This is somebody who had apparently erbium with a colleague, and I just don't think they did a good job of blending out, which is a problem. And then sometimes patients, because they're so fair complected, have etched lines, they may have a good result on the area that you do the heavy resurfacing, but this patient has rosacea and sun damage. She just wasn't good about sunscreen, wasn't good about changing her habits. So I think you can potentially see improvement, whether it's the laser or the bimatoprost we heard yesterday. You can see improvement in these types of things. So that's been my approach. Thank you.